Hello and welcome to your postpartum patient-centered maternal care and medications. All right, so where we're going to start is we have now moved into beyond the fourth stage of labor. And what we're expecting at this point is that you approach the head-to-toe assessment with the expectation that certain things need to start happening. For example, we need the uterus to start involuting, which means going back on itself to return it to its normal size. What people feel after the delivery, they think that once the baby's out, that they're done with the pain, but the uterus has to continue to contract down. So after pains tend to be worse in multiparous women because what we have is that the uterus has to work harder to get back to its original size. So where you have benefits of being a multiparous mother with having a shorter labor, you will have also the increased pain with that uterine involution. Okay. Anytime a mother is breastfeeding, she is going to feel contraction pains because that's the oxytocin being released from the nipple stimulation and the breast milk letdown. And so that makes more contractions happen. People will also feel little gushes because every time that uterus makes a contraction, and they're still, or we'll call them after pains, but it's still the same physiology as a contraction. They will also have whatever has pooled in the vagina be released by that contraction, that after pain. This is where we come back to our concept of fundal height assessment. So at the first day postpartum, we'll see that they are just 1 finger breadth over the umbilicus. And then each day you can expect that they will move a finger breadth down. By about day 9, we're getting close to our pre-pregnancy state. Other things that we're assessing is that our lochia is going to change, which is that cleansing and releasing of the uterine lining after the delivery. So the way that the uterine lining built up in menstruation to be released, it built up to support the pregnancy. And then after the pregnancy is done, now that extra layer has to release itself. So we expect that to be bright red, regular red, or we would even say dark red, but not clotted. Okay, even though you could have like little bits of clots in there. Then we'll see it become more serosanguinous, just like the output that you would see after a surgery in a Jackson Pratt drain, for example. And then it will become like a whitish, grayish kind of discharge. It smells fleshy, but should not smell like eggs or infection. The other thing that we expect is that the cervix has to recover as well. So any injury to the cervix, vagina, or the perineum have to be assessed. All of this can take about 6 weeks to return to the pre-pregnant size. The nursing care is also assessed based on diuresis. So the double increase of the fluid volume to support the pregnancy, the body has to get rid of all of that fluid. So if you take that concept back to the fact that we double our blood volume to be able to support the pregnancy, and then if we had any complications with the pregnancy that caused retained fluid, or we had a problematic strip with lots of periodic changes, then we were fluid resuscitating. And so we have all that extra fluid that the mother's cardiac system has to navigate. So mother will diurese by urine, by sweat, okay? So these are the things that we want to assess. So if we know we're diuresing, that means we know that the bladder is going to be constantly getting full. And if we know that the bladder is the bully, and it can push the uterus out of the way, then we need to make sure we're assessing for urine output and for bladder. So here's a great little example of when the bladder is full and how it displaces the fundus. So you should find the fundus right in the center of the abdomen. You start with that measurement where you put the edge of your hand down into the umbilicus and you're measuring finger breadths above or below the umbilicus. So going more in depth into the postpartum bleeding, this is a great little infographic that kind of gives you a better sense of what to expect. So 0 to 4 days, 5 to 8 days, 9 to 14, and 3 to 4 weeks. Some of the things that I want to let you know is that what we're focused on for this, what you need to know for the course, is the ability to identify postpartum hemorrhage or to identify an abnormal variation. So I'm not going to ask you a question like, if I had pink-ish fluid on the 7th day, is that normal? I'm not going to ask you that. What I'm going to be asking you is, do we have bright red bleeding 14 days post? Okay, that would not be appropriate. So those are the things we're talking about. Make sure that you go back and review the chapter on the postpartum head-to-toe assessment, remembering that we have to support the lower uterine segment in our fundal checks, that we have to do peri-care wiping and lots of really great peri-care based on if there were any kinds of, well, obviously the perineum is traumatized, the labia, the vagina. There can also be dryness associated with the trauma to the exit of the baby or with the exit of the baby. So giving them Tux pads. There's also that increased pressure that creates discomfort if you already have hemorrhoids, or hemorrhoids could have been created in the pregnancy. So we use topical spray, we use Tux. The NCLEX likes to ask lots of questions around the little things that we do to ensure perineal comfort. Make sure that you use your Bubble E, Bubble V, just no Bubble He, okay? We do not do Homan sign, so make sure that you're aware of that. It's been disproven by evidence-based practice, but of course, again, if you see it on the NCLEX, they're talking about deep vein thrombosis, okay? So we have to make sure we're assessing breast, uterus, bladder, bowel, lochia, episiotomy, extremities, and emotion. And then if we have a tear, an episiotomy, or we're aware of a hematoma, then we want to do our RITA like we talked about on clinical day 1. Okay, and that is pretty much good stuff for any incision. The difference is that we tend to see more ecchymosis in delivery rather than in an abdominal incision, for example. Okay. So let's review the perineal tears as well. So we're looking at the different degrees, and you do need to be aware of the degrees of the tear because we shift our interventions based on that. So for example, the fact that the bowels slow down in delivery means that sometimes we have to provide like a stool softener, or we have to give something to make sure that there's not constipation, okay? So where we would need a stool softener is even more relevant if it were to be a 4th degree, for example, rather than a 1st degree, okay? So your 1st degree is just a tear here. Your 2nd degree compromises the perineal muscles, but it stops at the anal sphincter. Your 3rd degree goes, actually tears the anal sphincter, and your 4th degree completely tears through and exposes the rectum. Okay, you do need to memorize this because they do ask questions about it. We do not allow patients to just exist in this state. We're going to do all of the repairs that we need to, even with some of the smaller tears. So making sure that we're giving cold packs, we're giving ibuprofen and Tylenol. We tend to rotate those every 6 hours. And then making sure that the patient is staying hydrated, eating foods that won't cause constipation, lots of fruit, lots of things that will help the patient, get the patient up and moving so that their bowels can continue to be intact and able to, empty. Now, some of the other perineal trauma that we deal with is hematoma. So we know that the number 1 cause is uterine atony, okay, in greater than 70% of the cases. And we know what meds we use to remedy this, okay? Some of the other things that I want to bring your attention to is that the hematoma can cause occult bleeding, because if you can imagine how the vagina stretches out for the baby to exit, then you can well imagine that if there was a ruptured vessel, that a hematoma could become quite large, okay? So a patient that does not have clear lochia coming out when you're doing fundal checks could potentially have a hematoma. Now the hematomas need to get drained, and that's the way that we stop that hemorrhage from happening, okay? So be mindful of your numbers again. Be mindful of the maternal changes, which you're going to start to see that heart rate go up, then you're going to see the blood pressure start to shift, and then we'll see the oxygen sats change. Now all of these things too with changed, altered level of consciousness. So sometimes you can see people start to alter their level of consciousness, or they were engaged for the delivery and then suddenly they're very quiet. You want to be mindful of things like that, because the behavior could be a predecessor to your awareness that vitals have changed. But if you look at your patient and they were up and mobile and engaged and playing with the baby and, doing all of that. And then suddenly they're very tired and sleepy and they're not taking a nap. They're looking pale. Make sure you take a look at the blood pressure. Okay. We do associate primary and secondary hemorrhage. We look at primary hemorrhage within the first 24 hours. And again, that has to do with, uterine atony, and things like that. And then when we see it after 24 hours, then it could be something else. So that's actually quite abnormal. All right. Some other things to be aware of, again, like we talked about, is cervical lacerations. And we're going to get into that a little bit more because cervical lacerations can actually extend themselves into the uterus and compromise the uterine arteries. All right. So be aware of the risk factors like we talked about for postpartum hemorrhage, but what are the risk factors for a hematoma? We said that was instrumentated delivery, large for gestational age, or macrosomic baby. All of those things can cause trauma to the perineum. When we look at the cervical laceration, we're looking at a patient that is pushing when their cervix is not ready for delivery. Okay, so we need the cervix to be 10 centimeters dilated. If we have a multiparous mom, sometimes they will start to push at 8 centimeters or 9 centimeters, but because they've already delivered, the cervix will respond and it will not tear. It will actually dilate just from those couple of pushes. Now, when we have an uncontrolled descent, like in a precipitous delivery, then that we can see a cervical laceration. Okay. With a cervical laceration, we'll just sew it essentially back up together. And then we have to be aware for future pregnancies that now we have a compromised cervix or a cervix that has a history of trauma. Now let's see what that looks like. So if we recognize that we do have vaginal arteries, okay, it's not just tissue is being, supplied by blood vessels. Those vaginal arteries connect to the internal iliac artery. And if you notice, the cervix is the base of the uterus. You remember that from your anatomy and physiology. So now once that tears, we're looking at the possibility of exposure of a vaginal artery. If it continues to extend itself, it could also compromise a uterine artery. All right. Now here you can also see very clearly why, if we were to have a uterine rupture, this is a major hemorrhagic emergency for the mother as well as for the baby. So look at the proximity of the lower uterine segment C-section and why we don't always extend a C-section when we have a really big baby. Okay, so a lot of times if you're sitting in a C-section and you're like, oh my God, why don't they just, or my goodness, why don't they just extend the uterine incision? This is why they can't. Okay. Now recognize too that if we have traumatized the vagina in the delivery with an instrumentated delivery, you can see here how these these vaginal arteries will bleed to create a uterine hematoma. These hematomas can extend up into the perinatal cavity, and I'll show you that in just a second, but they are quite severe. Okay. Here is also where you can see where an ectopic pregnancy rupture is a medical emergency. All right. And then here you can see that we would get the patient for a cervical laceration back to the operating room, put them in stirrups. We need full light and full equipment to be able to pull the cervix down and suture it. So here we can see the hematoma again, where it is in the lower part near the vagina here. And then here you can see where it's so significant that it extends itself up into the abdomen and can actually displace the uterus, causing uterine atony. Okay, now this is a different view so that you can see how profound these hematomas can be and that people can lose liters of blood into a hematoma. So speaking about DVTs, amniotic fluid embolus or pulmonary embolus, okay, what we have is, for example, we talked about a shoulder dystocia where we're hiking the legs up out of the range of motion, or if we're pushing for a really, really long time and the patient is in stirrups for a really long time, that can cause some trauma to the tissue, create inflammation, and then that will create a clot in superficial veins that travel to the great saphenous vein and become a thrombophlebitis by moving up into the body. Now we also have deeper clots, which are the deep vein thrombosis. So you have the superficial and then we have the deep. Okay, so this process mirrors exactly what you learned in Med-Surg, so you don't have to study this unless you didn't learn it properly the first time, but you can see that there's a significant difference, and your interventions of measurement, assessment of heat, redness, all of that is very, very clear. Okay. Now, the amniotic fluid embolus is different than a DVT that goes up into the lungs, which you learned about in Med-Surg already. The amniotic fluid embolus means that there was some compromise of the connection between the placenta and the mother, where amniotic fluid got introduced to the maternal circulation, and that causes like an anaphylactoid response. Okay. So that anaphylactoid response, with the introduction of the amniotic fluid into the maternal circulation, will find itself in the heart and then eventually find itself into the lungs. Now, you don't need to memorize this process. I am not going to ask you or test you on this, but I need you to be aware of it for NCLEX purposes, okay? What I would want to know more than anything is which patients would be at risk for that. And your answer to that question should be any patient with a placental abruption, because we've had an injury there, a patient that was in a motor vehicle accident or experienced a kind of trauma could have had a disruption somehow between the maternal and fetal circulation, and that's where the amniotic fluid embolus would happen. Okay. Here's a picture too. The amniotic fluid embolus, or the anaphylactoid syndrome, is something that results in left-sided heart failure. And then what we end up having to deal with is a patient that moves into DIC and hemorrhage. These patients can have strokes due to cerebral infarction related to the widespread vasoconstriction. And the only way for us to be able to say that it was an amniotic fluid embolus is that we do an autopsy, because the mother died. Okay, so the only time we can say somebody's had an amniotic fluid embolus is if the mother dies. Okay, so let's talk a little bit about metritis. Okay, metritis means infection in the actual uterus itself. And these things can happen related to needing to do bimanual massage if you have had a postpartum hemorrhage. So one of the things that we will do sometimes in a postpartum hemorrhage, if we can't get the uterus to clamp down, is we have to do bimanual, which means we insert the fist up in through the vagina. We put pressure on the lower uterine segment, and then we come up above the abdomen and we do fundal massage while we're doing that internal massage as well. This is usually in the case of an emergency where we have a mom actively hemorrhaging and we're trying to stop the bleeding. Once we get the bleeding stopped, we have introduced an entire appendage, essentially, of bacteria that has been a part of grabbing the baby, maybe doing pericare during the pushing because there was a little bit of stool that came out because they were pushing right. You know, those kinds of things like that. It's a dirty environment. Vaginal delivery is considered dirty. That's why we want to maintain sterile technique as much as possible. So once that physician has done bimanual massage, which is picture A here, then our mother needs to get antibiotics, okay? If we have to use the Bakri balloon, or they call it the Ebb balloon, this is a balloon that causes uterine tamponade, and we insert it almost like a catheter, but we do it through the vagina and into the uterus, and then we fill it up with a lot of water. And it has a little opening at the end, which catches any bleeding, and then that bleeding moves into a Foley catheter looking bag, okay? We fill it up to a certain amount, and we have to be very careful because we don't do aggressive fundal massage with this because we can cause the balloon to be dislodged. All right. We also should not see a lot of blood coming out because that means that the uterus is still bleeding and there could be retained segments. Generally, they've confirmed that there are no retained segments before they put the Ebb or the Bakri balloon in. There's also a balloon called a Jada, which is new. And you can look that up on the internet. We will not be testing to that or discussing that further because it's so new. It's not going to be on your NCLEX at this point. What we do after it's been in place, usually for a minimum of 24 hours, is we start to systematically empty the balloon to confirm that there is no longer any bleeding. Okay? So with the introduction of the Bakri or Ebb balloon, or what we call the uterine tamponade balloon, we also have E. coli available, right? If the mother was GBS positive, then we also recognize that she's already at risk, and then we ended up doing bimanual massage or a Bakri balloon. The infection travels up north, okay, and this is also the same way where we get chorioamnionitis from poor sterile technique with vaginal exams, okay. This is where you see that the infection can actually permeate all the way through to the perimetrium. So what you need to know and memorize is signs and symptoms of infection and the risk factors associated with why the patient could have gotten metritis in the first place. So fever, uterine tenderness, feeling sick and flu-like, and then having continued abnormal bleeding that is bright red beyond the time that it should be. Here, what we have here is postpartum mood disorders, and this falls on a spectrum. So what we have to do is assess what's normal. When you have a newborn, it is expected and normal that you will be sleep deprived. It's also expected that you'll be bonding with your baby. Breastfeeding is generally going well, but you're tired. Going out's different, but it still feels like it might be enjoyable. Food is good and nourishing, and you worry about things like, what is the next outfit my baby's gonna wear? Life's different, but you're excited or at least neutral about it. And after a few weeks, you're feeling good or at least neutral about it, right? You're not feeling bad, like you're a bad mother. You're just feeling okay. Once we have baby blues, which is also normal, but it only lasts about 2 weeks. And baby blues generally has a lot to do with the hormone cascades of the body returning back to normal, okay? Or returning to the pre-pregnant state. So this generally only lasts, again, about 2 weeks. So anything beyond 2 weeks is a concern. You're so sleep deprived in this situation that you're actually a little emotional, okay? You're bonding, and it took a while, but it definitely happened before the 3rd week. Breastfeeding's been hard, but you can do it, and you've got support. You've reached out for support. Going out's harder, but it still sounds like a good idea. Food feels good, but only if it's what you're feeling. You worry, is the baby getting enough milk? Because you're having some breastfeeding issues. The changes have made you feel overwhelmed, but it's pretty manageable. And after a few weeks, you feel like you're coming out of it. When we move into the mood disorders, then we're looking at behavior that is not congruent with what is appropriate based on normal and based on the natural hormone cascades of the body returning to the pre-pregnant state. So the person now is starting to demonstrate a change in personality. They're irritable, they're angry, they could even be ragey, right? Very reactive. They're not bonding. Breastfeeding is impossible. They don't like it. They're not looking for help. They don't want to go out. They don't want to eat, or they're eating everything. Okay, they're worried about everything. They're trying to establish control, so they become very difficult. And then you start to doubt about being a mother, okay? If you made the right decisions. And then after a few weeks, nothing gets better, okay? So we know for a fact that we're having an issue. Every single mother is assessed for this before she is in labor. When she's first admitted, she's assessed for it in the antenatal period. She's assessed for it before she ever decides to get pregnant, and she's assessed for it after delivery in the postpartum phone calls. They do phone calls to check in on people, and then again in the postpartum checkup. So you can imagine that if we only do a phone call about a week after, and then we don't reach out to these moms, it could be weeks, and they could be in a full-blown mood disorder by the time they ever get to their first postpartum appointment. Okay, so remember that assessment is required. We don't say postpartum depression anymore, but because we recognize that postpartum depression is only one component of this spectrum, okay? These things range from anxiety to panic all the way to postpartum psychosis, okay? Moms can become bipolar, and again, we talked about it in intrapartum. Labor can create trauma, all right? So some different types of things that we do is counseling, medication, support, exercise, sending in family to make sure the moms get sleep. I always tell my moms to let people wash your dirty underwear because moms get embarrassed about things like that. But that kind of support is what you need after delivery. In this country, or developed, or technologically savvy, whatever you want to call it, Western, there is not a lot of postpartum support. If you move into different areas like South America, Mexico, you're looking at India, Africa, there's an entire community that descends upon the family postpartum and actually helps with the care of the baby, the care of the mother. Like in India, they get massaged every single day for the first 60 days postpartum. Full body massage, the mother and the baby. Okay, how many of you's lives would be different if you got a massage every day for 60 days after you had your last baby? Okay, so with postpartum mood disorders, the treatment options, again, bright light therapy. There's a phenomenal program, I believe it's in Ireland, where they bring the moms in patient with the babies to recover from postpartum depression and postpartum mood and anxiety disorders. Okay, so make sure you're clear on your risk factors, because we want to assess that the mother's at risk way before the baby's born. We want to get them on meds that they need way before delivery so that we can navigate that process safely and no one gets hurt. So bringing us forward into lactation, also recognize too what's happening with progesterone, with estrogen, okay, and why postpartum blues or baby blues happens. You can see it right here, okay? The next thing that we see too is how these hormones interact when a baby is feeding, okay? So in the pregnancy, we have increasing levels of prolactin because we want to start creating that colostrum. Progesterone maintains the pregnancy, okay? Estrogen levels are pretty high because we're moving into delivery, and oxytocin is actually pretty low until the actual birth. So once we have the actual birth itself, you see a surge in oxytocin because we need that uterus to clamp, and then we also need that milk to start to come down. Okay, so as you can see the correlation, once the baby feeds, the oxytocin level drops, okay, and then when the baby feeds again, then our oxytocin levels go up because we need to let the milk out, and so on and so forth. So you can see that these oxytocin levels correlate with the actual breastfeeding itself. Now, once the breastfeeding is done, then the body has to increase and create more milk, so you'll see the prolactin levels go up. Okay, so you can see all of these different hormones happening together, and you can recognize that as the postpartum period transitions, then the severity of the cascade of these actual hormones starts to stable out. Okay, so let's talk about real quick, reminding us of oxytocin. Okay, so oxytocin stimulates uterine contractions, pushes baby toward the cervix, the head pushes against the cervix, the nerve impulses from the cervix go to the brain stimulates more oxytocin goes into the bloodstream, and then it goes around and around in labor until the baby's delivered. Okay, so pretty cool to see the correlation of oxytocin in the pre-pregnancy state, and during the pregnancy, during the labor and delivery, and then postpartum. All right, so let's look a little bit at breast care and breast formula versus formula feedings. We talked about the process and the hormones, and I can tell you many times over, 99% of problems with breasts are related to the poor latch of the infant, or what we call a shallow latch. So we have multiple breastfeeding positions here that you can see. We've got a cradle position, a cross cradle, laying on the back, the football, which is one of the favorites. I always teach side lying as well because mothers are exhausted. We have a side lying cradle. We also have inverted side lying. There is an Australian hold, or what we call like a saddle, which means like the baby's sitting on your lap like he's riding a horse and feeding that way. Now, the thing about breastfeeding is that the baby can breastfeed in 365 positions. These just happen to be the ones that mothers prefer. Okay, but recognize that if we have a mother that has a uterine incision from a C-section, that uterine incision becomes compromised, and then all of a sudden they have a wound vac, it's going to be very hard for them to put a baby on their abdomen or near their abdomen. So positions that allow for the baby to latch without touching the mother's abdomen whatsoever are very beneficial. Okay. So let's look at this latch again and recognize what we talked about with the stimulation on the top of the baby's hard palate, right? We want to aim the nipple at the nose, put the baby's chin at the base, and what that does is make the baby open his mouth to get on top and above to latch onto the areola. So once the baby's latched onto the areola, then the actual pulling is happening and the bite is happening up high. Okay, so it's not really a bite, it's a suck. When they use pacifiers, they actually bite. Okay, so that's why we discourage the use of pacifiers or bottles, because the baby's jaw has to make a bite to be able to get the milk out versus a wave. Okay, and that's what that looks like. So you can see the baby's jaw and tongue lift, and then they pull the nipple back, and then that releases the milk, and then the baby opens again, and the process goes on and on. So again, majority of problems with breastfeeding have to do with an improper latch, which causes trauma to the nipple. So once we have that trauma, then we have different milk ducts that are not emptying properly. And when that happens, then we experience clogged ducts, which can cause mastitis. Now, what you need to know about the actual breast is that every single breast will go through a phase of engorgement, which is the first major letdown of milk for the baby. So what we say in our breastfeeding teaching is that the second night sucks and the breast generally looks normal, right? So the baby on the second night has had the 24 hours recovery time, right? Or 18 hours recovery time, and now they're eating every 2 hours. This is usually where moms start to get frustrated, but this eating of every 2 hours, like we said, second night sucks because the baby's sucking the whole night, is what creates that engorgement process and that huge letdown. So the breast can be very firm and hard and sore, and extraordinary pressure onto it can cause a lot of damage. So what we do to treat that is we do nice warm compresses, because we're trying to get the milk to release, and we're trying to do comfort care. Now, recognize that if we have a perinatal loss and we have a delivery, but we don't have a baby to eat, this engorgement process still happens. Okay, so when that happens, what we want to do is use cold interventions, and we want to use things that make like Benadryl to dry up. Okay, so that we can navigate and we don't encourage more milk production. So what we tell people is to take like cabbage, because it is something that makes you dry up, and we have them keep it in the fridge. And then right before they're, when they're feeling pain, then we have them crush it up and stick it into their bra. And what that does is it helps to cool the breast, and it prevents more milk production. The other thing we tell people to do if we're trying to stop the milk is to wear a very tight or firm fitting bra. Okay. So again, we're looking at, in the process of engorgement, is there a baby for us to encourage milk letdown, or is there not a baby where we want to help the mother to stop the process? So you have to know your interventions for both. Okay. With mastitis, we also do use warm compress, because if we have a clogged duct, we're trying to get that duct to dilate so that whatever the clog is can release itself. One of the best things to release the clogged duct is the baby continuing to breastfeed. Okay, so you just have to do it in a safe manner, and babies can continue to breastfeed while a mother is on antibiotics. So let's see what the breast looks like. So you'll see an inflamed red hard spot, or multiple spots, that will demonstrate where the actual clogged duct is. Okay, so this is what engorgement looks like. But as you can see here, you can outline the actual gland itself. So you can see the gland clusters here, and then those clusters drain into the areola and the nipple. So where we get the clog from the improper latch, now this is backing up and becoming infected. And whenever we're not letting fluid out, just like a UTI, if you're holding your pee all the time, then the bacteria starts to crawl up the urethra. The concept is similar here with the breast. So what you'll see is staph infections and MRSA, because it's related to the skin. Okay. So let's look here a little bit at what we expect for breastfeeding. So day 1 would be like a calamansi, which is like a little tiny lime-like fruit. By day 3, it's pretty much the size of an olive. Okay, and then this is actually a Mediterranean fruit. And so many people haven't seen it, so I won't show you that one, but we can look at some other analogies. And then by 1 month, the amount of milk that's available is the size of a chicken egg, a normal large chicken egg. So imagine that this milk is pretty powerful because you only need a tiny bit to fill up the baby. And then as the baby gets bigger in his days, and you start to see the milk amount and consistency change. Okay, so breast milk is the perfect combination of proteins, fats, vitamins, carbohydrates, and it also has all those living antibodies that the mother can pass to the infant. There's also benefits to formula feeding. So please recognize that there is a lot of psychosis that we put our patients into because they feel guilt or shame because they're not effective in breastfeeding. Now that's frustrating because if we provide the right kind of support, everyone would be successful in breastfeeding. But because the hospital system and birthing is a business, then you recognize that getting the patient out so that we can open up the space for another delivery is part of the process. So it's up to you to advocate and educate yourself in breastfeeding practices if you're a labor nurse, postpartum nurse, antepartum nurse, ER nurse, okay, to be able to recognize how to work with these moms so that they can have a nice and long breastfeeding career. But if they cannot, to empower them and support them in what happens with formula feeding so that they are okay to go. All right, so here is a better example. So we've got the belly balls, which is a shooter marble, which is the bigger marbles in a bag of marbles if you've ever played with them. And then you have a ping pong ball, and then you also have a chicken egg, and then pretty much by a month you'll see them with the size, well, the adult has a softball size stomach, so you can see the difference. Some important points around bottle feeding is that we want to make sure that the baby is always in control of the flow. So what you'll notice is that this baby does not have the bottle on the side, because a lot of times people want you to lay the baby down with bottle feeding because they're saying the baby's going to get air, the baby's going to get colic. Well, that's what burping and farting is for. Okay, if you do a really good burp and fart on your baby, you never ever have to worry about that. What ends up happening when you make the bottle vertical into the baby's mouth is that milk continues to drip and the baby can't stop that flow. So the baby swallows and swallows and swallows, and the baby clears out that bottle pretty quick. So family members are like, look, see, aren't you glad you bottle fed? The baby was starving. Not necessarily. It could have been that the baby couldn't stop the flow, so they chugged it down. And then the way you know that it was too much is they start to spit up afterward. So the proper amount of breast milk and the proper amount of formula in the bottle when we hand it over to a mother is important. So we do not fill up a bottle and give them a 60 milliliter bottle like you see the formula companies provide. We're going to pour that out and give them probably between 10 and 15 milliliters for their first feed, preferably 5 to 7. Okay, so then we gradually move that up. We also expect to see some differences in the stool. So every single baby has meconium after they're delivered. Even if they've passed a little bit of meconium in the womb, sometimes you will see some remnant in the first couple diapers. What you'll notice too is that breastfed babies tend to have a much brighter yellow type of stool, and it has what looks like cottage cheese curds in it, okay? Or they will say it's seedy. A formula fed babies is more thin, okay? And it's a little stinkier. If the baby has iron in the formula, you'll actually see green in the poop. What we don't want to see is slimy stool that's yellowy greenish, because that usually is diarrhea, or we actually see blood in the stool. So this is not okay. This is, an emergency essentially. So besides the assessment of the diaper, we also recognize that we have to teach parents about the diapering, about what to look for, about the fact that babies get dehydrated very easily, especially in the state. We want to teach them about safe bathing practices, like not taking them into the tub without the proper basin, because babies have slid down into the water and aspirated and gotten pneumonia or even drowned and died. The other things that we want to make sure we teach parents is that no powder, baby powder is no good whatsoever, because what they find is that the talcum gets up into the baby's airway and it creates a lot of problems. We also don't want to use a bunch of lotions. Most baby's skin is okay on its own, but if you do, make sure that you try it on a very small part of the baby's skin, so that if the baby has a reaction, we're not dealing with a baby that has, a allergic reaction through their whole body. We recommend that you put the lotion on your hands first and then on the baby, so that you can make sure you have the correct amount, you can warm it, and then you can massage your baby with that. Other thing is that no baby leaves the hospital without a car seat. And so if any support is needed for a car seat, we do have many programs available where we will give a family a car seat. Okay, so with safety for the neonate, we've talked about powders, we've talked about making sure that we have a car seat. The other thing that we have now is something called safe sleep. Okay, these are the do's and don'ts. So make sure you review them, because this is part of health promotion and maintenance, and this is part of preventing some of the most traumatizing kinds of losses of neonates in the first 30 days of life. Okay, so you'll need to know what kinds of situations will put a patient at risk, or a neonate at risk for shaken baby syndrome or SIDS. We're not going to get too heavily into that because you look at that in peds, but know that anytime we have an unhealthy pregnancy and there's alcohol, drugs, social issues, there is food insecurity, the patient is homeless, anytime we have any kind of social disruption or a non-healthy pregnancy, then we have a risk for SIDS. So always back to sleep is the term that we use. So baby is on their back for sleep. We use a firm and flat, safe mattress and a safety approved crib. We do not have anything in the crib whatsoever. So if you're concerned about the baby's temperature at night, what we recommend is warmer jammies or pajamas, okay, or sleeping clothing. They also have like sleep sacks that keep the baby from getting tangled up in sheets or baby bumpers or things like that. We recommend, we do have the fact-based and evidence-based correlation that there is less situations where we see sudden infant death syndrome in babies that, higher incidence in babies that are bottle fed, and lower incidences in babies that are breastfed. Okay. We recommend sharing a room. We do not recommend co-sleeping, even though culturally many families choose to co-sleep. That is not necessarily a problem unless there is drugs or alcohol, or the individual is either partner, the mother or the partner, or husband, wife, whatever, are heavy sleepers, because they can actually roll on the baby and suffocate the baby. Okay. Where we discourage pacifier use for breastfed babies, they do state that pacifiers are recommended for safe sleep. Again, that is a very personal decision, but they say that if the baby's swallowing, then he's not going to aspirate. So they suspect that SIDS could be related to aspiration. They associate it with temperature, increased temperature, and they associate it with all of the social concerns that we spoke about. Okay. They also recommend that babies have supervised tummy time, so that allows them to start to develop the muscles of the neck to be able to lift their own heads. And we do have a developmental expectation of when they should be lifting their head on their own, but again, that will be covered in peds. All right. Make sure that we avoid smoking at all costs. When we do have a family that has a smoking parent, we recommend that they go outside to smoke and that they use a smoking shirt, because the nicotine gets into the clothing, and then when they carry the baby gets full of nicotine. So a smoke shirt, and then we have them smoke outside, and then they wash their hands and take off their smoking shirt before they pick up the baby again. Interestingly, we absolutely encourage breastfeeding with mothers who smoke, because the baby will go through nicotine withdrawals. So the amount of nicotine in the breast milk is significantly decreased, and that helps the baby to recover from the nicotine in the body being cut off because they're not receiving it through the blood in the pregnancy. Okay. All right. So shaken baby syndrome. I always say, feed your baby. Feed your baby. Okay. Whether it's a breast or a bottle, feed your baby. Try not to drop your baby, and never, ever, ever shake your baby. Okay. So the reason why it's so severe is that the majority of the baby's weight can be up to about a quarter of the total body mass. So since the neck muscles are weak, what we end up with is a very heavy ball, almost like a bowling ball, and shaking that back and forth, which causes trauma to the neck and also causes trauma to the blood vessels and injury of the blood vessels and the dura membrane, bleeds beneath the subdural space. And so this actually tears, and that makes the bleeding happen. Okay. What we will also see too, if you notice, is that we will have babies that have bloodshot eyes, or they have petechia in the eye, and that is one of the cardinal signs of shaken baby syndrome. Okay. So babies, once they have been shaken, they will have decreased level of consciousness, problems feeding. A lot of times this happens with a caregiver. Usually it's someone that they know. This isn't like the movies and Lifetime Movie Network where, you know, they get the new babysitter and the new babysitter shakes the baby. And that happens. It could be a sibling. It is a spouse or a partner in many of the cases, or a primary caregiver. Now remember, primary caregivers are not always the parents, based on the work schedule and the social situation. All right. So again, we talked about kangaroo care. You've seen this photo before, and the importance of that kangaroo care, particularly in preterm babies. Tummy time, again, like we mentioned a little earlier, helps not only with the neck and strength development, but also helps with back posture, helps stretch and develop the legs and hips. Remember that they were like a little C inside the womb in most cases, so that tummy time allows them to start to stretch out, helps with strengthening the hands and all kinds of wonderful things. So we do like tummy time. Tummy time is also helpful with the shape of the head. So if we have a baby always on his back, then the back of the baby's head becomes flat. Or if the baby's always on their sides, like we see a lot in preterm newborns, and the head becomes flat on the sides, and all of that. We need a round head for the brain to develop and grow in it. So making sure that babies have tummy time is very important. Okay, so lastly, making sure that we're supporting the mother and getting used to her new body image, which is very different than, you know, the pretty pregnant body or the body that she loved before she ever got pregnant. And so it's very important to help mothers to get used to that, to normalize it. It's been really nice to see a lot of celebrities showing their postpartum bodies, so that it helps to decrease the stigma. Coping skills, again, are key. And incorporating the entire family into the care of the newborn, and that newborn teaching is paramount to make sure that mother has support and that baby's safe at all times. Anytime you have a skill that you are teaching the family, you want to make them do it. You want them to demonstrate that they can change a diaper, demonstrate that they can feed their baby, demonstrate that they can burp their baby, demonstrate what a safe crib looks like. Okay. Involving grandparents and siblings is always wonderful, but we, again, like we talked about way back in antepartum, you want to have the sibling involved based on the developmental age. So we're not going to leave an 8-year-old watching a newborn. Okay, so even though we do have situations where older siblings will be caregivers, we really want to find support wherever we can to get that, so that we avoid a child developmentally taking care of a more vulnerable neonate. Okay, sex after baby, again, is after 6 weeks, once birth control method has been established, because that body needs a minimum of a year to recover from that delivery. Again, asking people to come in and help, doing a meal train, all these things are really wonderful supports. We want the family to not be overly stressed, if at all possible, so that we can encourage attachment. All right. Follow-up care, again, like we talked about, is that birth control back on board, as well as Kegels, which are the pelvic floor exercises to get the pelvic floor back to its pre-pregnancy state. Very important to recognize that you will be asked questions on the NCLEX around what kinds of tasks or patients can be assigned to a CNA or an LNA, which is the licensed nursing assistant, or an LPN. So we do utilize CNAs and LPNs in the newborn nursery. So you will be asked questions associated with babies that are stable, and then maybe there's one unstable baby, or maybe having to pick which baby can be cared for by the LPN or the CNA. So now moving back into women's health, we recognize that there is a normal loss of elasticity of the pelvic floor as we move into the time of menopause. But before that, we can have issues with prolapse. Okay, so things like urinary incontinence happens because they've lost a tone from many deliveries. And we know that pregnancy is one of the #1 causes of these pelvic floor pathologies. So our normal anatomy without a prolapse, we recognize that we have all of these wonderful ligaments keeping our uterus in place, our bladder in place, and the actual walls that separate the bladder and the uterus and the bladder and the vagina and the anus are very well intact. Once we've had trauma to the perineum, we could end up with something called a rectocele. So cele is kind of like a protrusion, and then this would be a protrusion of the rectum through the vaginal wall. Okay, so there is no break in tissue here, only that this rectum is collapsing against the vaginal wall. Okay, when we see a cystocele, cyst means bladder, and so we can see the bladder prolapsing into the wall of the vagina. We can see a uterine prolapse, and I've actually seen this in delivery, where the uterus itself drops out and you see a donut. And when you look at it, you're like, is that a cervix? Yes, it absolutely is. Okay. And then we can have an enterocele, where we have, so enter means, entero means small intestine. So we can have a prolapse of the small intestine in this direction. And you recognize that there's no uterus here in this case. Okay. We can also have a collapse of the vaginal vault. So questions that you'll be asked will be related to what kinds of problems would you see in a patient that has a cystocele. So you're thinking about urinary incontinence, vaginal fullness, pressure, things like that. If we have a rectocele, we're thinking about constipation or diarrhea or problems with the physiological process of whatever it is that's prolapsed. Okay. Stress incontinence is also something that happens, which is when I sneeze, when I laugh, there is a dribble of urine. And so what we do to remedy that are the Kegel exercises. To remedy the prolapses, we use pessaries, or actual structures that will replace, or not replace as in take out, but reestablish the placement of whatever it is that is prolapsing. Okay, or creating a barrier between one wall and another. All right. So we will review why we use alpha-adrenergic blockers and anticholinergics, and this will correlate with men's health and why we use the medications that we use for them as well.